ICU at Vanderbilt's Medical Center. A third of the 35 beds hold flu patients.
This is the worst flu season we've seen in probably a decade.
Yeah, so like the news clip said, the flu season this year has been terrible. I've got the graph from the CDC on the screen here, but you can see that here in January of 2025, the influenza A cases especially have really been running rampant. My name is Brandon. I'm a board-certified pediatrician and pediatric ICU doc, and today I want to talk about influenza. Specifically, I wanted to look at two different things. So one, how can you tell if a child has influenza, and do they have the same symptoms as adults? And then secondly, if you think your child has influenza and you want them to be treated, why is it critical that you get to the pediatrician within 48 hours of symptom onset? I do want to say I'm actually getting over the flu, kind of motivated this video, so I apologize. My voice is kind of raspy and nasally. It'll be better by the next one, I promise. So to start off, when people say they have the flu, sometimes they just mean it in kind of common language that, oh, I just have like a cold or I'm not feeling good, or sometimes they have the stomach flu, which is really norovirus and a different infection. But to me, when someone says they have the flu, when I say I have the flu, what I mean is I think I have the influenza virus. So remember, influenza is not so different from a bunch of these other common viruses that cause respiratory tract infections. So rhinovirus, the old coronaviruses, human metapneumovirus, parainfluenza, they can all cause infections of the respiratory tract. In this list of viruses, I do think influenza and COVID are a little bit different. One, in the symptoms that they produce, but two, importantly, that we have treatments that go directly after them that can be commonly used that we don't have for those other viruses. I don't want to dwell too much time here, but just know that when you hear about the flu in the news, there's a couple different types that cause disease in humans. Type A and B are the most common that will cause human outbreaks. Type C does a little bit, but don't worry about it. And then when you hear these subtypes, again, I wouldn't think too much about it unless we're talking about the bird flu, the H5N1. Just know that the most common recently have been H1N1 and H3N2 for the A type of influenza. These names are really based on the proteins that make up the structure of the influenza virus. And just note that these that cause outbreaks every year are variable year to year, and that's why you actually have to get a new vaccine each time. Okay, so we'll jump straight into how do you normally tell the difference, in adults at least, between influenza and the common cold, those other viruses we talked about before. Well, the first thing to note is that the symptoms are usually pretty sudden. They hit you really hard, really fast, usually within 12 to 24 hours. And then the second thing is the primary symptoms are a little bit different with the flu or influenza. So if you have fever and chills, body aches and muscle aches, fatigue and weakness, and headache, and those are kind of the prominent symptoms, that suggests more flu or influenza compared to the common cold. Now, if you get the flu, it is very likely that you're also going to have those common cold symptoms, congestion, sore throat, cough that accompany it, but they might not be as prominent as the other ones that I mentioned. Okay, great. And that's true in adults, but is that true in pediatrics? Of course not. No, everything is more difficult in pediatrics. So there was this study where they had 353 kids who were diagnosed with influenza and treated in the outpatient setting. And they looked to see, all right, what symptoms are they experiencing? I probably should have not even had this table on here, to be honest, because it's so busy. But if you focus on the left column, you can see the symptoms that they looked at that were most common at the top to least common at the bottom. And then in the far right, it kind of says the percentage of how frequently they saw those symptoms. So you'll see that fever is the most common symptom and most important in identifying influenza. When you go down though, the next most common were rhinitis, kind of like runny nose, and cough, which are very common in the common cold, and they aren't those differentiating symptoms that we saw before. And so you go down a little bit and see headache and muscle aches, which is myalgia. Those are pretty uncommon. Only like 26 and 7% of patients had them. And to make matters worse, if you look at the under 3-year-old age group, they just said not applicable. Because with kids, it can be really hard to tell. Do you have a headache or do you have muscle aches? If you're 18 months old, how are you supposed to tell your parents what that means or how that feels? So it can be really difficult. The conclusion the authors had was listed here. All right, diagnosis of influenza is difficult, especially in the youngest children. Thankfully, there are really reliable tests available. So if you go to your pediatrician and it's during the winter months when flu is raging, it's very likely that they will send a flu test. And you can get pretty rapid turnaround to figure out if flu is present or not. Okay. And now the critical moment comes where we say, hey, we have the flu, should we treat or should we not? And this is where I'm looking here at Tamiflu, or oseltamivir, which is the most common antiviral for influenza in the US at least. It says very clearly on their ad here, see a doctor quickly. Treatment should begin within 2 days or 48 hours of flu symptom onset. So why are they saying that? Well, The studies that looked at oseltamivir, or Tamiflu, generally showed that it can shorten the duration of illness by about a day in most patients, and it can reduce the likelihood of complications, for example, a pneumonia, secondary bacterial pneumonia, or something like that. But it's most effective when it's started within 2 days of symptom onset. So this is really critical, where if you want your child to be treated, you have to get them to the doctor early so they can be evaluated and see if they have the flu in that 48-hour window to make a decision. Okay, so let's say you get the child to the pediatrician, they have influenza. Who has to be treated? Where it's really kind of like no compromise. So children who have severe illness, if they get to me in the intensive care unit, they're hospitalized in the ER, and they have really severe disease, then they will get oseltamivir, and honestly, we will treat them whether it's in that first 48 hours or not. But also high-risk children. So let's look at this table, but any children under 2 years of age are high risk of developing complications. Also those with lung disease, immunocompromise, other serious systemic illness are ones that should be considered as well. But then there's a big group of patients who could be treated but are not necessarily required to be treated. So on the last slide, and this is true for me, for children who are 2 to 5 years old, I will often encourage treatment because they are higher risk of complications, though not as bad as the under 2-year-old age group. So I think most purists would say, hey, you have to treat under 2, you don't have to treat between 2 and 5. But this is from the American Academy of Pediatrics guidelines, and you can see that there is some flexibility with treatment here based on parental preferences and the pediatrician's preferences. So even if you're an otherwise healthy child, not at high risk of influenza complications, if you get there within 48 hours and you're interested in treatment, then it's something that can be done. And then similarly, if you have high-risk contacts in your home, say they're immunocompromised, very young children, then it may be worth treating them as well. So I'll say there's probably a lot of variability in influenza prescribing practices. There are many purists who I think very reasonably would say, look, if you're otherwise healthy, then giving you this medicine, this Tamiflu, that has side effects, has risks, it's only going to shorten the duration of illness like 17 to 30 hours. So I really don't want to do it. But there are others who may say, yeah, I mean, it could shorten the duration of illness and prevent complications and prevent spread, so it might be a little bit more flexible. But a lot of that will come down to your discussions with the pediatrician. And then the last thing I'll say, there are side effects for Tamiflu. It's overall well tolerated, but the most common thing is nausea and vomiting, so probably 15% of patients get it, or some abdominal pain and diarrhea. And much more rare, but could cause some confusion, or kind of we say neuropsychiatric side effects. These are much less common. Most common thing I would say is nausea and vomiting. So if you reasonably decide, hey, you know what, I don't want to use Tamiflu, my child is over 2 years old, they're not high risk of developing complications, it's not going to shorten the duration of illness that much, just realize there are other symptomatic things that you can do to support your child. First, treating fever and discomfort. So though less common if they have headache or sore throat or muscle aches, then giving Tylenol, not for infants under 3 months old, or ibuprofen, not for infants under 6 months old, can help with that. In other videos, we talk about how to relieve nasal symptoms, but a couple drops of saline and suctioning can be very helpful. Nasal ipratropium over 6 years old, and actually using nasal decongestants is okay over 12 years old, but should definitely be avoided in those younger age groups. And then finally, for cough, honey is actually a really great treatment. You have to be over 1 year. There's some risk of infant botulism, so really do not give this to children under 1. But other than that, it can be very helpful with coughs. As pediatricians in general, we really suggest against, we call them antitussives or anti-cough medicines, things that have, say like dextromethorphan. In general, they have a risk of harm, but really don't show as much benefit in kids, and so would avoid those. So I think that's all I really have to say about the flu. It's been a tough viral season, but again, for most kids over 2 years old, they're gonna be fine. They don't need to have Tamiflu, though it could help them feel better, maybe reduce the risk of complications. So that's an individual decision for each parent and pediatrician to come to. And once again, hope you enjoyed the video. So like and subscribe. We'll do more videos about this sort of evidence-based pediatric content. But more than that, if you're willing to leave a comment on any questions you have or other videos that you'd like to see, go ahead and let me know, and I appreciate your time. Thanks.